Good morning, everyone. My name is Jen Hastings, and I'll be your host today. I'm happy to welcome you to our CME, Building Resilience, as you implement ACEs screening in your practice, how to care for yourself while guiding patient care. This learning session is sponsored by the Health Improvement Partnership and Central California Alliance for Health, our managed Medi-Cal, serving the Tri-County region, serving over 340,000 members, Santa Cruz, Monterey, and Merced counties. So we are thrilled that you're joining us. We have a wonderful agenda planned for you today. Very simple. We have Dr. Susan Swick from Ohana. We have Dr. Lisa Gutiérrez Wang from our own county behavioral health in Santa Cruz County. And then we'll have time for questions. I want to go through a few of the logistics. We're recording this webinar for those who can't attend in person today. We ask that you complete our survey at the end of the webinar. This is what will allow you to get your CME or CE. And we have beginning and ending codes in that survey that you need to put in, and we'll be sharing the beginning and ending codes. And in fact, the beginning code is, I'll get it to you right now, 9963. So just write that down. 9963 is what you need as your beginning code. And the link to the survey will be in the chat box at the end of the webinar. We are really looking forward to your questions, and those you can put in the question and answer box that's on your screen. We'll be tracking those and collecting them during the talks by both Susan Swick and Lisa Gutiérrez Wang. And we are thrilled that they will be able then to answer the questions together and have a bit of a dialogue together. So let's move on to the next slide. We like to know who's here today, so we're going to have a poll where if you could please share your, let's see, I've got the polling questions right here, your work setting and your discipline. If you can please share that with us. And then Susan and Lisa will know a bit about you, and that will help them focus their conversation as they work through us. So if you can please share your work setting and your discipline right now, check the little boxes, and then we can collect the poll while I speak a bit about Dr. Swick, Susan Swick. Susan joined us last year, a year ago in June, when we did another CME focused on behavioral health. And I am just so thrilled that you're with us again, Susan. Your ease and depth and breadth of knowledge in the field of child psychiatry and family, really family care, is extraordinary. And I'm thrilled that you're with us today. Susan will be focusing on ACEs screening, learning about risk, and cultivating resilience in ourselves, which we really need in order to do this work. So, okay, here we have primary care 20%, mental health 7%, good showing from substance use disorder folks, some social service providers, hospital care in the schools, and then 41% other. So that is interesting. So we'll see what those maybe, and we'll learn a bit more about that in the questions. And then in terms of discipline, I can't see the whole thing. There we go. Okay, got it. Yeah, so 14% MDDO, 7% nurse practitioners, RNs, 21% LCSW, LMFT, some SID, some CADEC, and then medical assistants. So glad you're here. The team-based care for this work is so important. And then 7% administrative, and then again, 21% other. Okay, Susan, just very briefly, Susan is, as I said already, child psychiatrist, came to this area, Monterey, Santa Cruz, what, a year and a half ago, or maybe a little bit, and is at Ohana, our medical director at Ohana, providing groundbreaking approach to child and adolescent care. And we're thrilled to have you, and we're gonna pass the torch.
Okay, can you hear me? Okay, perfect. I'm a Luddite, so everyone signal if you can't hear me. I'll be watching Jen to see if there's any problem. Good morning, everybody. I'm so delighted to be here with you. I wish I could see your faces, but I'm going to feel your spirits as we get to discuss screening for adverse childhood experiences so that we can learn about our patients' risk and help them cultivate resilience. Now, I'm not going to be speaking explicitly about how to care for ourselves because it's all going to be sort of baked into the cake. As we talk about adversity, risk, and resilience, it should be clear that this doesn't just apply to patients, this applies to all of us as human beings. So hopefully these are lessons we can internalize and then share with our colleagues, our families, and our patients. Okay, let me see if this works. Aha, it worked. Okay, so on to our goals. Now our goals today are fairly straightforward. We have 3 learning objectives. I hope after the next hour that you'll feel comfortable describing 3 of the potential adult health outcomes of serious childhood adversity, and 3 elements of human resilience, as well as 3 practical strategies to cultivate resilience. And you'll see those little symbols on the giveaway slides. So if you're wondering where they are, you can figure it out. Okay, so let's just dive right in. Now, I'm sure that all of you actually have a lot of expertise on adverse childhood experiences or ACEs, but I like to do a quick review of what Anda and Felitti established as the specific 10 experiences that contribute disproportionately to risk of changes in biology and behavior that can lead to serious health outcomes in adulthood. And I would like to talk about this for just a moment because these are clearly not the only adverse experiences that children can have. But we're going to talk about why I think they're critical ones to bear in mind, but we also want to think a little more broadly when we're assessing adversity about the range of adverse experiences. So we can see in these 10 that we're talking about serious adversity. It's abuse, physical, emotional, or sexual abuse, neglect, physical or emotional neglect by parents or adults of children, and other kinds of household dysfunction, but serious household dysfunction, right? Mental illness or substance abuse in a parent, an incarcerated relative, divorce, or witnessing domestic violence. And I want us all to notice that in each of these instances of these specific 10 ACEs, it's either a parent that is the source of adversity or who has been impaired by the adversity. And this is so critical because parents really are MVPs as children are younger and younger. Parents are the critical buffers for adversity, difficulty, or challenge. Because as we're going to discuss, adversity is actually just part of childhood. It's an essential part of childhood. And most of it is not negative. Most of it is necessary, uncomfortable, but necessary. But when adversity impairs a parent's ability to buffer or is coming from a parent, a child's ability to manage it or master it is also going to be very impaired. Okay. And we also know that ACEs are exceptionally common, right? So nearly 2/3 of us has an ACE score of at least 1, right? Nearly 2/3. These are serious adverse experiences. And 16% of us have an ACE score of 4 or more. And we'll learn that 4 is a pretty critical tipping point in terms of serious outcomes. And we know that having the serious childhood adversity, and this was well established by the study that Anda and Felitti published in '97, coming out of Kaiser, for behaviors and even changes in biology that lead to serious health outcomes, both physical health and mental health outcomes, right? So adults with an ACE score of 4 or more are twice as likely to be obese. They're twice as likely to smoke and 7 times as likely to abuse alcohol or drugs than the general population. They are 4 times as likely to have emphysema. They're 5 times as likely to have depression, and they are 12 times as likely to attempt suicide in their life as the general population. They have higher rates of heart disease, of cancer, of stroke, of COPD, of autoimmune disorders. And those with scores of 6 or more have their life expectancy shortened by 20 years, right? It's an extraordinary level of risk. And it makes sense that we should want to know about this level of risk, right? In our adult patients or in our pediatric patients, because it gives us the power to then try to intervene to mitigate that risk, to improve health or to address illness where it's beginning to emerge, right? Now, beyond time, which is always an obstacle to implementing new procedures in our busy practices, there are some internalized obstacles to screening our patients. And one of the obstacles that I want us to think a little bit about is thinking about whether we are screening our pediatric patients, children, are we screening adult patients, or are we working with families? There is a real pattern of generational transfer of adversity for reasons that actually don't even require much explanation, where a parent who has a very high ACE score is much more likely to be struggling with health problems, mental health problems, addiction. They're much more likely to be victims of domestic violence, so that their children are in turn likely to experience a lot of childhood adversity too. So how do we think about the point at which we intervene? A second obstacle to screening is the fear of opening Pandora's box, right? Worrying that we're going to ask a patient about an experience that is so traumatic, that has been so boxed up or sealed over, that we may uncork it, and we may not be able to access the resources or supports we need to help them manage. And it may feel like it's better left carefully and safely boxed up. And then lastly, is thinking about managing ourselves. ACEs are common, right? 2/3 of us have at least one. It's entirely possible and actually very, very likely that in supporting patients, we may also be triggered or be touched in ways that may be draining, exhausting, difficult to manage. But I want you to come out of this talk feeling empowered and hopeful, right? Remembering that knowledge is truly power. So knowledge about ACEs, knowledge about adversity, knowledge about risk, and then knowledge of what we can do about it. So we're going to spend most of our time talking about resilience and how adversity is an essential part of resilience, and how we are continuously building the muscle of resilience. We're going to talk about how some routine habits of self-care are critical to cultivating resilience. Although my little icon doesn't look very routine. I don't think any of us are doing the rings for self-care, but there aren't that many icons, so there you go. And then finally, knowledge of when to ask for help. And the Cliff's Notes is early and often, never worry alone. Okay, so let's talk about resilience. What is resilience? As you know, essentially it's a very simple definition. It's a capacity to adapt in the setting of adversity. And resilience is a little bit of a buzzword right now. I get the New York Times on Sundays, and I feel like every week, almost every section has an article on resilience, from the book review to the education section, to business, politics. certainly styles, health and wellness. But I want you to know that resilience has actually been a buzzword in psychiatry and child psychiatry for the better part of the last century. We've done a lot of studies in that time to better understand what predicts resilience. And we've found a few fixed factors. Gender predicts resilience. Women are a little more likely to be resilient than men. Sorry, guys, but we'll take that one. Intelligence predicts resilience. And a few features of temperament, such as being curious in novel situations and having a sunny or more extroverted temperament predict resilience. But far and away, the strongest predictors of resilience are learned skills. And the first one that I'm going to tell you about is something called the internal locus of control. Now, I apologize for all of psychiatry and psychology that we call things words like internal locus of control rather than something catchy. But essentially, this is a concept that describes a person's belief that the circumstances of your life are a function of your choices, right? Now, this is not a delusional belief that you control the weather so that you can stop the rain from falling on your head. Nor is it a denial that there are real things that happen in your life over which you have no control. Instead, it's an appreciation, an understanding that the choices that you do make do have consequences. And if you don't like the circumstances of your life, you can examine those choices, make some different ones, and gradually change the circumstances. So I like to use a hypothetical example to try and explain this concept. Let's imagine that a child psychiatrist was invited to give one of the keynote presentations at a CME conference on ACEs, screening for ACEs. And it was terrible. It was terrible. Now, if that child psychiatrist had an external locus of control, they might respond by saying, well, what did they expect? How am I supposed to give a talk about adversity and childhood stress when I can't see anybody's face? How am I supposed to give a talk at 8 o'clock in the morning about something so abstract? And Jen never told me that I wouldn't be able to see everybody else in the Zoom conference. And how am I supposed to manage all this technology anyway? I'm a psychiatrist, not an engineer, right? So everything is not my responsibility, not my fault. A psychiatrist with an internal locus of control instead would say, that did not go very well. Maybe next time I should learn a little more about what they're hoping I'll talk about. Maybe I should find out what conferences they sponsored for the last 2 years. So what their membership is used to hearing about. Maybe I should speak with the other presenter beforehand and find out what her presentation will include. Maybe I should generate my talk a week before and practice it a few times, right? So you see, it's a focus on those things that are in your control so that you think about the next time. Now, all of us know somebody with an external locus of control because they're very difficult to work with. They're always rejecting responsibility, not my problem, not my fault. They're difficult patients to care for. They're help rejecting complainers in our old parlance. But the truth of the matter is that all of us have a capacity for both an internal and an external locus of control. And it often takes cognitive practice to shift your focus to what you do control and to get better and better at moving towards that internal locus of control. So I tend to think that stories are more memorable than studies or definitions. So now I'm going to tell you a story about resilience, and particularly a wonderful illustration of that internal locus of control. See if you can remember it. Now, I like to ask if anyone knows who this is, but I can't see you, so I don't know if any of you know who this is. But if you're a student of contemporary art, oh yes, excellent. David, you got it. It looks like Lou Reed, but it is, the gentleman with the beard is Chuck Close. And the large gentleman is his good friend, Philip Glass. And Chuck Close is a very successful American painter. He became famous in the 1970s for his large-scale photorealist portraits, like the one you see here of Philip Glass. But Chuck Close was not a child that anybody would have labeled most likely to succeed. He suffered from severe dyslexia. And it was undiagnosed. In the 1940s, they really didn't have a description of dyslexia, especially in rural Oregon where he was growing up. And instead, he was felt to have a very low IQ. In fact, his teachers told his parents that they should just withdraw him from school. They said it was hopeless for him to be going to school, and instead they recommended he become an auto mechanic. But I mean, it must have been much simpler to be an auto mechanic in the 40s, because now you need a PhD in computer engineering to be an auto mechanic. He also had a neuromuscular condition that made coordinated gross motor activity really challenging for him, right? So he actually couldn't run, throw, toss, or kick a ball. So now we have a boy who could not play sports very well, and was really struggling academically. That's 2 strikes. Then when he was 11 years old, his father died suddenly and unexpectedly of a catastrophic brain aneurysm. And that same year, his mother developed breast cancer. After getting a kidney infection, Chuck Close stayed out of school for almost a year in middle school. Now, if I heard this story in my child psychiatry clinic, I'd be extremely worried about this boy. But Chuck Close had a talent and a love for art. And he had parents and one teacher who helped cultivate that love. His parents got him to art classes when they could afford it, and they drove long distances to take him to museums when they had the time to do so. Now, Close later said, art saved my life in 2 ways. It made me feel special because I could do things my friends couldn't, and it also gave me a way to demonstrate to my teachers that despite the fact that I couldn't write a paper or do math, I was paying attention. Right now, this is a glass half full kind of guy. He's not in denial. He has a clear understanding of his strengths and his limits, but he's able to focus on what he can do, right? This internal locus of control. Incredibly, it turns out that Chuck Close actually has prosopagnosia, which is an inability to recognize faces. And he reports that this actually made drawing and painting faces very compelling for him. He said he felt like he could master the differences between faces by flattening them out, turning them into component parts. So you can see how the obstacles in his path contributed to his efforts. The challenge contributed to his mastery. Okay, that's enough resilience for a lifetime, but Close's story of adversity does not end here. In 1988, he suffered something that he calls the event. It was a catastrophic spinal artery rupture, right? It left him paralyzed from the shoulders down. Now, I'm sure he had very, very dark days, and over many months and over years of rehab, he was actually able to recover some of the use of his upper arms. And Close turned his focus in his rehabilitation on how to return to painting. He designed special splints that would hold brushes for him. He designed a special wheelchair that pitched him forward so that he could paint. And here he is. This is just in the last, I think, 15 years, painting one of his portraits. And you can see that he's developed a new style of painting where he's able to create these small cubes, sort of an expanded pointillism. And all together, they create a portrait. He produces 3 works a year, and he's even created a foundation to support art classes in public schools in impoverished neighborhoods. This is a portrait he did of Philip Glass again with his new style, right? So Chuck Close is a marvelous illustration of the internal locus of control and the role of adversity, setbacks, failures in building mastery and cultivating resilience. And Close also illustrates another critical ingredient in resilience that I'm going to tell you about beyond the internal locus of control. And it's something called meaning making. Now, meaning making is not just a kind of saccharine pep talk, right? That which does not kill you makes you stronger. It's true, but that's not what we mean by meaning making. Meaning making instead is a capacity to take a loss, a failure, or a tragedy and to place it into the overall narrative of your life, right? And to then gather the fuel so that you can face it, headed towards a transcendent goal or purpose. Okay, and you can see I'm going to tell you another story to help you remember this concept of meaning making. This gentleman is, does anyone know who this is? You won last time. This is a little older. This gentleman is Viktor Frankl. Frankl was a psychiatrist in Austria in the last century. Living in Vienna with his wife in the 1930s, he practiced psychotherapy, he wrote books, and he was teaching at the medical school there. By all accounts, he had a very successful and happy life. But it was 1939, and Frankl was Jewish. By 1942, he and his wife had been sent to live in the ghetto, and in 1944, they were sent to Auschwitz. Years later, Frankl wrote of a moment that he was walking through the camp at Auschwitz, ruminating about whether he should trade his last cigarette for a bowl of soup, when he was suddenly struck by how utterly devoid of meaning his life had become. He was disgusted and despairing, and he realized that he was going to need some purpose beyond mere physical survival if he was going to come out of this experience with his spirit and his soul intact. So Frankl began to envision himself giving lectures after the war, lectures about the psychology of life in the concentration camp. Now, he didn't know how the war would end. He didn't know if he would survive, but he was a student of human behavior and he was a teacher, right? He was able to acknowledge his terrible reality and then focus on concrete goals that were meaningful to him, part of the larger story of his own life. And this enabled him to transcend this profound suffering and carry on. Now, of course, we know the war did end. He wrote a beautiful book called Man's Search for Meaning. I recommend it. It's very readable. And he gave those lectures to many medical students and psychology students. Now, his brother, his mother, and his wife did not survive the concentration camps. And yet Frankl managed to come through his trauma and his grief and become productive again in a way that he found meaningful and satisfying. Okay, so these are 2 very memorable stories, I hope, and they illustrate 2 critical concepts. And I'm gonna summarize then the last pretty much 60 years of research of what are the critical ingredients in resilience. Now, most psychology texts and studies will create a list of somewhere between 10 and 20 constructs that are critical ingredients in resilience. But I found a wonderful article by a business journalist named Diane Cotu that summarizes the psychological literature. And she boiled it down into three components, three categories that are critical for resilience. And I think that her conceptualization is really memorable and valuable. I renamed it. I renamed two of them so that I can remember it. And the first category is for a person to be perceptive, right? To be resilient, you need to be perceptive. Now, this sounds very simple, but it's not always so easy when what you have to take in is an unwelcome, difficult, or even traumatic reality, right? This is the ability to face, describe, and bear reality, not just the facts on the ground, but the feelings that those facts may create. You have to be able to bear all of that in yourself and even in those around you. You can see how the internal locus of control is critical to being able to sustain perceptiveness in the setting of tremendous adversity. Okay, so first one, be perceptive. The second component is putting this new unwelcome reality in perspective, right? This is taking a difficult event, a trauma, a loss, a failure, a setback, and not being defined by it, but instead placing it into the overall context of your own life story, who you are, what your talents and gifts are, what your transcendent goals or purpose is. Put it in that meaningful context. Make it a part of your life story and a part of where you're headed in a way that helps keep it in perspective. Right? And then the third component of resilience is something that Kotu called bricolage. I haven't given it another name because there is no other word that captures this. Bricolage is a word based on a French verb, bricoler, that has two meanings. The first meaning is to tinker, to use what you have at hand to create something that you need, essentially to MacGyver, for those of you who are of the vintage that I am of. Right? You can improvise with what you have at hand to create something you need. The second meaning of bricoler is it describes the rapid darting movement of small mammals being pursued by a predator, of all things. Only the French would have one word that means these two things. But you can see how these two meanings are so critical. Okay, Rita, let's go back. Sorry, I'm almost done with the last one. So bricolage describes the capacity to take creative but prompt and decisive action. Look around at what you have at hand and act. And then to be able to assess whether what you're trying is working and correct course if you need to, right? So creative prompt action with flexible course correction. Now, I want you to look at these three components of resilience and notice the first two are cognitive skills, and the third is a behavioral skill. But what really matters is all three are skills. Resilience is not a trait. People are not born resilient or not resilient, right? Resilience is a muscle. We're all born with muscles. A few of us are born slightly more athletic than others, but every one of us can build our strength, right? You exercise those muscles. You have to work them against some resistance. You build a resilience by facing, managing, and mastering adversity. Okay, now we go to the next slide. I'll let you do it. Rita, do you want me to resume? Let's see if I can do it. Ta-da! Okay. And we build resilience over the course of our lives. That when an infant is born, they have pretty minimal resilience. They're almost entirely dependent on their parents, on their greater family, and then on the community around them to manage adversity when it comes, right? Their one capacity is to cry, to command and collect help. But as we get older, in the weeks and months and years that follow, children are actually accumulating the building blocks of resilience, and they're beginning to face, manage, and master small adversities, so that they start to internalize all the skills that we just talked about and learned about, so that when they're adult, they have internalized capacity for resilience. That doesn't mean that we do resilience alone. Being connected to important other people is critical throughout life, but we've internalized most of the basic skills, right? And thinking about how we do that as children helps highlight why ACEs can be so toxic for children and when they become adults. So you can see basically that as children grow, which is what I was describing, they face challenges, and we can imagine a challenge is going to be learning to walk, learning to ride a bike, going to school for the first time, trying to master something, a difficult cognitive task, or a difficult physical task. And they have to face that challenge. They have to manage it, and managing it and mastering it actually involves a lot of setback and failure. It's not a linear response. You manage, you fail, you manage, you succeed a little, you go around and eventually get to mastery. But as they experience mastery, you build self-confidence, meaningful self-confidence connected to experience and knowledge of what your skills are, knowledge of what you're good at, knowledge of the landmines for you, as well as your interests and abilities. So that when you face the next challenge, you're better equipped to face it, manage it, and master it, right? So this brings us back to this idea of childhood adversity, and the idea that some adversity is a normal part of childhood. It never feels good, but for all of us, it is essential to development. But there is such a thing as bad stress, not just good stress, but bad stress, right? And we have a few categories here that help us expand our thinking about childhood adversity. Certainly life-threatening experiences, right? Witnessing a violent crime or having one's own life threatened, or witnessing someone else's life be threatened, usually overwhelms our capacities, at least in the short term. But importantly, of people who experience a traumatic, life-threatening event, 2/3 will recover without developing PTSD or other psychiatric conditions, right? Because they've internalized a capacity for resilience. Whenever a child has experienced the betrayal of a fundamental trust, when they have faced adversity in childhood that was created by their parents, or where their parents were impaired or affected and not able to buffer them, then they are at more serious risk. Any experience that has contributed to a sense of shame in a child or an adult is generally the kind of adversity that is very hard to recover from without extra support. And then I want us to think a little bit about these last two. Sustained or compounded stress and catastrophic or overwhelming stress. Catastrophic or overwhelming stress is going to describe a stress that is sudden and unexpected and overwhelms one's existing resources. So imagine a spectacular hurricane with flooding in which one suddenly becomes homeless and perhaps has lost their job. So that's one catastrophic event, but where there's also compounded stress, right? You lose your home, you lose your job, there may be financial difficulty. Sustained stress may describe living in a neighborhood with a lot of violence, facing systemic racism every single day. And it's really critical to conceptualize the idea of sustained or compounded and building stress for two reasons. One, it becomes especially critical for children facing sustained or compounded stress that they have intact buffers, that their parents, their families, and their communities are intact and present and able to help them buffer that continuous stress. And continuous stress is particularly toxic because we all need a chance to rest and recover. Think about it, when we talked about building resilience is like building muscles. And when you're doing an intense workout, you need to have time to put the weights down, drink a Gatorade, take a day off so that your muscles can recover and be ready for the next day or the next week, depending on how often you work out. When you are facing sustained stress every day, maybe every minute of every day, you don't have a chance to rest and recover. It's very hard to meaningfully build resilience. Okay? So, all of this should not be discouraging to you, but instead should help you conceptualize how big your patient's dose of adversity is. So you can imagine a child who has witnessed domestic violence and their parents are now divorced, right? And let's say those are the only two Anda and Felidi ACEs that they have. So they have an ACE score of 2. But let's imagine they're also living in a dangerous neighborhood, and it's a child of color facing systemic racism. So they have an ACE score of 2, but they also are facing some sustained stress. And their particular ACE score, right? So they have maybe only one parent that they can depend on, and that parent may be recovering from the experience of trauma, so that they do not have maybe the intact buffer. So you want to be more worried about that child than maybe another child with an ACE score of 2. You want to think a little more broadly about the stresses that they're facing. Okay, now Dr. Gutiérrez Wang is going to be talking in much more detail about how we screen for ACEs or PEARLs. But I'm going to talk a little bit about it and about how we integrate what I've just talked to you about resilience in the screening process. So first, you want to keep in mind your goals, right? And your goals when you're screening are for the experience to be a calm one. This means whether you are screening a child, screening an adult, or screening a parent and their child together, you want the experience to feel calm, not agitated, not intensely stressful, but it should be one where they're talking about something difficult, but in a setting that is comfortable. The second goal is for you is knowledge. You're gathering knowledge about their level of risk and a little bit about their narrative, who they are, and you're conferring knowledge about resilience and what they can do, right? You want them to know that the past is not the future, right? Your other goals are to normalize these experiences. This is not to say these experiences are good, but to point out it's not their fault, right? And in fact, these are very common experiences, and we know a lot about how to help children, how to help adults, and how to help families who've been through this kind of adversity. And you want them to come out of the experience feeling connected to you. In the same way, you want to preserve your connectedness to your colleagues, right? So doing this as part of a team is critical. And I often find it's helpful not just for me to think about how to do things or what to do, but instead to be thinking about how to be whenever you are taking about a task. So I'm going to talk a little bit about what your posture should be when you're doing a screening. Now this applies to all of us. I know that we have physicians and nurses, we have social workers, but we also have some administrators here in the audience with us. And for each of us involved in caring for these families, in creating a web of connection with each other around these families, thinking about your posture, how you can be interacting with one another, but also with your patients is very important. And the first one is calm. You'll notice calm was the first in both goals and posture. And this is because calm is contagious. And also it's simple, but it's not always so easy. And these features of your posture go in order. So the first and most important is for you to be able to be calm. If you can't, either because you had a fender bender on the way into work, or because a particular patient really pushes your buttons or has you very stirred up or upset, but you need to be realistic about what you need to be able to be calm in doing this work. Because if you can't be calm, you can't do the next things. You can't be curious, right? And the next feature of your posture is that you want to be genuinely curious. And by this, I mean open ears, open mind, open heart, curious. You're really listening. You really want to unpack. You may not have an hour and a half, but you want to make sure a patient has answered questions or told you a story so that you genuinely understand what they're telling you about. Now, this is going to require that you're able to bear what they're telling you about, both the facts and the feelings, right? So you need to pop up your, if you can't stay calm, you're not going to be able to be curious. And as you're bearing it with them and learning about it, then you have the opportunity to show compassion, right? To validate their experience. That was difficult. That sounds like it was frightening. Or what courage you had. Patients will let you know if you got it wrong. But when you sense that you're at a moment of being able to observe the way something made them feel, you offer it to them. They'll let you know if you're wrong, then you back up. You go back to curious if you got it wrong. Say, well, help me to understand more about it. But if you've got it right and you've been able to validate part of their experience and really understood it, and then you can move on to being the humble expert. And I mean by humble, they are the experts on their story, on their experience. But you will bring some expertise now on adversity and how it can create risk, as well as resilience. So you have something to offer them for what they can do to cultivate fitness, mental fitness, resilience, so that they can manage current adversity and future adversity and build real health. And then last, you get to be a cheerleader. Now, being a cheerleader without doing the other four things can feel hollow and meaningless. So you don't start with cheerleading. You have to be able to bear the tough stuff. But then being able to cheerlead for the small ways that they may be making behavioral changes that are going to build resilience is really critical. Okay, so if resilience is a muscle, your job becomes helping your patients or your family members or your friends or yourself to build that muscle, right? How do we do that? You remember what the three critical sort of components of resilience are, but the ways we build a muscle are to slowly exercise that muscle against resistance, right? So reframing adversity as a challenge, not a threat. Now, I don't mean to suggest that every adverse experience is a challenge and not a threat. If someone's pointing a gun at you, it's a threat. So it has to be realistic. But instead, thinking about how other adverse experiences, let's say the loss of a job, may be difficult, they may be unwelcome, but rather than seeing them as a threat that must simply be escaped or maybe numbed out, instead they are challenges, and challenges that can be met, right? And every challenge is an opportunity for practice. Now, we like to practice building our resilience muscle against small adversity if we can. So looking for every small challenge or setback and thinking about, where's my internal locus of control? Where are the things that I have some control over that I could do? How does this setback fit into my narrative about who I am and what my transcendent purpose is? And what can I actually try? And then how do I correct course if I need to, right? So what is your narrative? Then really critically is thinking about how do we help our patients keep our batteries charged, right? So when you're doing workouts, when you're exercising muscles, you have to take a break between reps. You can tell I don't exercise all that much. I have to think about it. But between reps, we have to hydrate. We have to make sure we have good nutrition. We need to take good care of the machine if we're going to put it through stressful experiences to make it stronger. We also need to keep our battery charged or do good maintenance on the machine. And then finally, we need to know when to ask for help. When we're working out, sometimes we need a coach or a trainer. And likewise, we may need guidance or help when we're building our muscles or our patient's muscles. So let's talk in a little bit of detail about those self-care skills. And how do we keep our battery charged? Now, there's a long list of strategies for self-care, but I've created this sort of dopey acronym to help me remember what they are, of Mr. Sense, right? And I'm going to give you a little detail about each of these, and as I keep my eye on our clock, on our time. So the M stands for mindfulness. And mindfulness essentially is practicing, it doesn't have to be meditation, it doesn't have to be yoga or another sort of strict mindfulness practice. Mindfulness is practicing an ability to non-judgmentally observe and accept strong feelings. And whatever practices help people. For some, it's meditation. For others, they may find that it needs to be connected with exercise or with knitting or with therapy in order to cultivate this capacity to non-judgmentally observe and accept strong feelings. The R stands for relaxation. You probably won't get too much of a fight from your patients when you say, we need to think about how to relax. But the truth is, very few people have really developed a thoughtful and nuanced sense of what helps them relax, because it's very individualized. Not everything is relaxing to everybody. For some people, a relaxation is a hot bath. For others, it's playing drums really loud. For others, it's going for a run. And for others, it's a good read. So you want to make sure your patients, as well as yourself, music is a wonderful one, have thought about and even consciously built a list of what are the strategies, what are the activities that when I'm done with them, I feel calmer, right? That they've helped everything to quiet a little bit. They may even feel a bit recharged by these activities. They may be creative, like making music or art. They may be distracting, like passive but engaging activities like watching a movie or a TV show, or more engaged activities like reading a book. They may be repetitive, like going for a walk or knitting. And there's a long list. If your patients only know how to have a drink at the end of the day, that's not a good list. If that's their only strategy for relaxation, it's a pretty empty one and will probably get them in trouble. Okay, sleep. Now sleep is third in my acronym, but actually I would say sleep is number one in our self-care skills. If all of these skills are not where they ought to be, the first one you want to pay attention to is sleep. For ourselves, for our friends and family, and certainly for our patients. Helping your patients to build healthy sleep hygiene practices, going to bed around the same time, having a routine that helps them unwind and relax, protecting sleep so that they wake up well rested and recharged is critical. Probably the most important way we and they will keep our batteries charged. So spend a little time on sleep hygiene if you only have a little time. The E is exercise. So for patients for whom exercise is not relaxing, we still want them to exercise. Getting your heart rate up 3 times a week is as effective as SSRIs at treating mild to moderate depression and anxiety disorders. And it is a spectacular strategy for taking good care of our bodies and our minds. Now, all of these things, well, we'll talk about at the end the ways in which you change habits, but nutrition is N, right? And healthy habits of nutrition. This doesn't mean that we're all eating kale all the time, but helping your patients think realistically about how food should be a source of pleasure and joy, but it should also be sustaining. And can they use food in healthy ways to connect to others, but also to honor their body and take good care of themselves. The next S is for social connections. And the ways we keep our batteries charged include cultivating nourishing social connections. So thinking with your patients about who do they have in their life that they can turn to, either when something wonderful has happened or when something terrible has happened, who leaves them feeling more charged up after they've spoken with them. Right? These are connections where people feel valued and valuable. These are connections where you feel bigger and better after every interaction. And we also want to help make sure our patients don't have social connections that are draining, because there are sometimes connections that leave you feeling empty, hungry, and less than afterwards, right? And then the E is engagement. Do we and do our patients have activities and work that we find meaningful, that we find engaging, not just a job for money, but work, hobbies, or friendships that confer a sense of satisfaction and meaning. When do we ask for help? I'm gonna try to fly through this one because, you know, strong feelings are normal in life, but depression and anxiety disorders are also pretty common in life. So all of you know that if your patient or a friend or family member has persistent sadness all day long or most of the day for most of the days over a 2-week period, you may be dealing with a treatable disorder and you want to ask for psychiatric help, you want to refer. If they have symptoms that really interfere with function, if kids are refusing to go to school or unable to make friends, if adults are unable to get to work, that's time for referral. If substance abuse is their main strategy for relaxation, you want to bring in more supports. It's not going to go away on its own. If there's any suicidality, you want to ask for help. And feelings of guilt. Guilt are common feelings with childhood adversity, but you really want to specify when a patient feels that they are presently a burden on people, that they feel guilty and burdensome. That actually is typical of depression in a way that's almost pathognomonic. So that you really do want to take that particular feeling seriously and expand your team. If you're working with a child and the parent can't do what the child needs, you want to bring more people into the orbit of that family. And you always want to remember it takes strength to ask for help and remind your patients of this. And since I mentioned parents, I'm going to end with a slide about resilient parenting. So whether it's for ourselves or for our adult patients who have children, thinking, it's often very powerful for our patients. It's hard to enact behavior change ourselves. It's easier sometimes when we're powerfully motivated, and having children can be a very powerful motivator. So being able to talk with your patients who are parents about what we know about raising resilient children. And it's fairly simple. Parents that are both attuned to their child and still able to create routines, set expectations, and create rules and limits. When they're able to strike a balance, right, between being really connected and still having expectations, the children grow up to be resilient adults. So thinking with parents about what it takes to be connected. Do they know their child's friends and mentors? That's kids and adults that are connected to their own children. Do they know their child's talents and interests? Those change over time. It can be as practical as, do they know where their children are and what their homework and assignment is that week? That's a good proxy for a parent that's connected to their children if they're up to date with those things. Can a parent step back and tolerate their child's distress and step in when they need to help their child face, manage, and master stress and adversity? Can a parent practice non-judgmental acceptance of big feelings in a relatively calm setting together? When a child falls off a bike and cries, can the parent acknowledge that it feels bad, but demonstrate hope that it's going to be okay and they can get back on the bike? And can they set expectations? Can they create routines and rules and then enforce all of these things pretty calmly and consistently? Now, this is not saying that parents need to be perfect. Oh my gosh, no way, it's not possible. But can parents aspire to these things, be constantly sort of working on these things? When they fall short, can they observe it? Can they own it? Can they even talk about it with their children? And can they live by the same rules and expectations that they set? To the degree that we can practice and model these things with our patients, we can talk about them with our patients who are parents. We're going to help them cultivate resilience in their children and help build a generation that's going to be ready to face the small adversities and some of the big adversities that we know we're all facing as a collective community right now. So thanks for your time and attention. I wish I could see your faces, but it's been a delight getting to discuss this with you. I'm excited to hear from Dr. Gutiérrez Wang.
Susan, thank you so much. I feel like you have grounded me in a profound way, and we don't have a lot of questions from folks, so we're just a reminder to everyone to please send in your questions through the Q&A. I want to appreciate your also grounding us in the present moment of two pandemics, COVID-19 and racism. I do feel grateful in a way for both of those. If we just want to look at like that moment of blue sky in China and people seeing the Himalayas, there's no way that this isn't truly catastrophic, and there's something that's happening that's important for the planet. And same with the death of Charles Floyd. We're seeing, we're learning and seeing and hopefully being called to action to end racism in our country and to move to do something about that. So thank you so much for your comments. I know Lisa is our next speaker, and so thank you. And we do have some polling questions before we bring in Lisa. So we want to know if you're currently screening for ACEs. So just take a moment to click a box. And who are you screening? If you're screening now or plan to screen. And then if you work in a primary care setting, do you have integrated behavioral health? So those are the questions that we want to hear from you about. And then while you're answering those questions, Lisa Gutiérrez Wang, Director of Behavioral Health for Santa Cruz County for the Children's Division, Director of Children's Behavioral Health, has dedicated extensive effort and focus on assessing and treating the effects of complex psychological trauma in ethnically and linguistically diverse populations. And Lisa, you've worked on the development of screening tools for ACEs, so we're really thrilled that you're with us today to share the tools that folks can use in screening. And I just also want to remind folks that the state of California has moved forward with asking primary care and pediatricians and all internists, everyone, to screen everyone for ACEs, and that's being paid for. Lisa, do you want to turn on your video and turn on your sound so that we can have you join us now? Thank you.
Morning.
Good morning. So I missed the panel. I guess it doesn't matter.
Well, it did look like the majority of folks were planning to start screening perhaps in the next year or have not yet kind of developed a plan to screen. It looked like the majority were working with adults, but definitely many of the folks on the call today working with children. So that was a great snapshot and a place to start our conversation today about screening.
Thank you. And yes, you're going to be talking about screening and anticipatory guidance and warm handoffs and kind of how to do it. So thank you so much. I just want to also say to folks that there is a 2-hour CME that the state of California provides and requires in order for you to bill and receive funding for that. And I just want to plant the seed that you all need to do that CME as well. Thanks so much. I'll pass the
All right, well, let's just see if I have control here of the slides so I can get started. Nope, shoot. Let's see, we'll go back. But thank you so much. So I'm Lisa Gutiérrez Wang. I'm the Director of Children's Behavioral Health for Santa Cruz County. But prior to coming to this position last June, I was the Director of Clinical Programs at the Center for Youth Wellness in San Francisco. And so the Center for Youth Wellness was developed or started, our CEO, by Dr. Nadine Gutiérrez, who's our current Surgeon General for the state of California, and is really the driving force behind ACEs Aware and the goal to really roll out universal ACE screening. So my role as the Director of Clinical Programs at the Center for Youth Wellness was to oversee our integrated behavioral health team, but also to train our partners at the Bayview Child Health Center and FQHC, so really training admin staff, medical assistants, and the primary care providers on how to screen for ACEs. So I'm really drawing upon that experience to talk to you today about screening children and youth in primary care.
George.
No? All right, so our objectives for today is really to clearly state the rationale for ACEs screening in primary care and also identify some of the associated barriers or concerns that folks have before embarking upon this work. We'll also take some time to really talk about the child and adolescent screening tool that has been approved for reimbursement through Medi-Cal, the Pediatric ACEs and Related Life Event Screener, or PEARLS. It comes in numerous versions and can be a little daunting, so we're going to spend some time talking about the different versions and how to really select the tool as you move forward. And then we're going to actually spend some time really talking about what can be done by the primary care provider in the visit to really provide intervention. And we're going to start really talking about anticipatory guidance. All right, so ACEs screening. Since Dr. Swick really provided us a wonderful framework for adverse childhood experiences and resilience, I'm just going to jump right in to start talking about the rationale for screening in primary care. So really this is identified as an ideal setting because screening, health prevention, and health promotion and disease prevention is already happening in this setting. But even more importantly, this really gives us an opportunity for early detection. Children come in multiple times within the first year of life for well-child visits. And then ideally they are coming in every year for ongoing care. And so this really does establish an opportunity for primary care providers to establish relationships with children and their caregivers early on and to really build on that relationship. You're seeing children and families, before children are entering school. So it really does give us an early opportunity to begin having these conversations. And once again, to really build on the relationship through these multiple touch points. But having said that, kind of this idea of the ideal place to begin screening for adverse childhood experiences being in primary care, we also recognize that there are a lot of barriers or challenges. And this is a list of several that come up quite regularly, and Dr. Swick did mention quite a few of these already. I will take a few moments to talk about the top 3 that when I was doing ACEs screening, ACE screening trainings came up most frequently. So those were lack of time, lack of provider comfort and fear around asking these types of questions, and then also concerns around not having a robust enough referral system, especially for those individuals that were identified as really requiring additional behavioral health services. So with respect to lack of time, there have been some pilots on ACE screening using various tools. And what they have found is that the actual screening process usually does add about 5 minutes to the medical visit or the appointment time. So that is really the introduction of the tool, the actual filling out of the tool by the child or caregiver, depending on the age, and then really making sure that that information is then provided to the primary care provider so that they can review it before actually going into the session and beginning to review it with the family. So lack of time is definitely a concern. As I mentioned, around 5 minutes is the data that we have with respect to adding this particular tool to a visit. And really the art is really understanding how to weave in ACEs screening and the review of the results into the appointment in the way that we're really reframing the way that we're talking about it, not necessarily adding additional tasks to the primary care provider in that visit. I will just mention that tomorrow, ACEs Aware is going to be having a webinar, and the two speakers who really do represent the primary care provider in this process, both Nadine Gutiérrez, who's a pediatrician, and Simone Ippoliti, who's a nurse practitioner, will actually be on that webinar, and they're going to actually talk about how they weave this into their work so that they're not extending the appointment time. And so really hearing from those providers, I think, can be beneficial. So definitely a plug for that webinar tomorrow at 12. With respect to lack of provider comfort, I think this comes up quite a bit with respect to, if I start asking these questions, I'm not sure what to do to follow up. If I start asking about abuse, neglect, household instability, it might be that the client or the caregiver actually begins to provide way too much information. I haven't been trained to be able to provide appropriate grounding or support to really contain that conversation. So a lot of concerns around just comfort, and once again, this sense of if I open this up, then the time that I have to be able to do all of this will extend what I have available for this particular visit. So one of the things that we'll be talking about with respect to the Pearls tool is the different formats. And really this can be a decision point around using an identified or de-identified version of the ACE screening tool. And so the identified version actually asks respondents to identify which categories of adversity the child has been exposed to, while the de-identified version actually just asks about how many of the categories of adversity the child has been exposed to. So one of the decision points often for folks who feel uncomfortable about opening up this conversation is a sense of really wanting to gravitate towards that de-identified version, which we can talk a little bit more about. Additionally, concerns about the strength of the referral system. So many primary care providers, say if I start screening and identify a need, how am I going to connect them with the appropriate services? Often identifying a lack of behavioral health providers or resources is a huge barrier. And so one of the things that we often talk about in ACEs screening is that so much can be done in primary care, even without a robust behavioral health system available to you. So part of what we'll be talking about with respect to interventions and provision of anticipatory guidance are some of the things that you as a pediatrician, a family medicine doctor can do within the session to really support children and caregivers who do have exposure to ACEs. All right, so we'll go ahead and keep going. So with respect to this ACEs screening protocol, one of the big pieces that I always emphasize is having a clear rationale for ACEs screening. So of course we are asking about exposure to abuse, neglect, and household instability. But ultimately the Pearls and really the ACEs Aware initiative is using exposure to adverse childhood experiences as a way to determine relative risk for toxic stress physiology. So this idea that exposure to adversity without sufficient internal coping resources or sufficient buffering can actually lead to the dysregulation of the neuroendocrine immune physiology and this dysregulated stress response. And so ACEs screening in this context is really to determine risk for toxic stress physiology. So recognizing that that's really the rationale can then really provide the framework for how we select tools and how we actually set up workflows. So clear rationale as to why we are screening for ACEs, then a clear understanding of what population you will be screening, whether that's children and their caregivers or adults, depending on your location and who you work with primarily, and then also the screening intervals that you'll select. So I will say that for reimbursement from Medi-Cal for children, the guidelines basically state that you'd be screening as appropriate or medically indicated, but no more than once per year per provider or managed care plan. So what that means is that potentially you could be screening children once a year at the annual well child visit. Or you could do that less frequently. There are some clinics who do annual screening, and a big piece of that is trying to normalize the screening for adverse childhood experiences, really normalize the conversations that they're having during well child visits around the impact of exposure to adversity and stress on health. Other clinics really do choose to screen less frequently. They may just be screening during the first visit, so the first time that that patient is coming to that particular clinic. So really clarifying the rationale, what you're hoping to obtain from this information, and then how frequently you are planning to screen, and how do you normalize that. I will mention that at the Baby Child Health Center, we began to screen at the 9-month well child visit. And that was really after a review of all of the well child visits that happened within the first year, and identifying which well child visit felt like it had enough capacity or space to be able to include the screening and the conversation, as well as a sense of at the 9-month well child visit, there had been a relationship established between the family and the provider. We had actually really begun to reconsider starting at the 9-month well child visit because we were getting a lot of referrals for integrated behavioral health services for children younger than 9 months. So we were getting referrals for 3-month-olds and 5-month-olds, and recognizing that the primary care providers were picking up on other cues. So they were picking up on the fact that the caregiver was struggling with significant stress or symptoms of depression, that the child actually was presenting with failure to thrive, that they felt was connected actually with the stress in the household. And so one of the things we were considering is actually to begin screening at the 2-month well child visit, and screening both the child but also the caregiver to really have then 2 data points on exposure to adversity, and then moving forward with plans to support that dyad. So really thinking clearly about who the population is, when do you start screening, and then at what intervals do you continue to screen. Another key piece of rolling out ACE screening is, of course, identifying the tool that you'll be using. And so today, as I mentioned, I'm going to be talking exclusively about the PEARLS tool, or the Pediatric ACEs and Related Life Events Screener. So I apologize for having, I wanted to put both sections in one slide, but recognize that you won't be able to read this. So I'm really just going to kind of go over what the different sections are, and then I'm going to talk about the different versions of the PEARLS that are available to really help you think through what tool might be appropriate for you if you are considering using or beginning to screen for ACEs in your practice. So the Pediatric ACEs and Related Life Events Screener was actually developed out of the Bay Area Consortium on Toxic Stress and Health, or the BARC. And so this is a partnership between the Center for Youth Wellness, the University of California, San Francisco, and UCSF Benioff Children's Hospital in Oakland. So this is work that started a few years ago, and the team was really looking at existing ACEs screening tools and really wanting to develop something that could be easily implemented within a primary care setting. So the ACEs, or this ACEs screening tool, the Pearls, has two sections, and really this is what is reflected in the slide. So part one are the traditional 10 ACEs. So that is the categories of abuse, neglect, and household dysfunction or household instability. It basically asks 10 questions. Each item is really associated with each of those categories. And so an individual can score from 0 to 10 on part one. So these are the traditional 10 ACEs that come from the Felitti and Onda study. They are the 10 ACEs that have the research that associates them with the negative health outcomes and the odd ratios for those chronic medical conditions. And so this section really is focused on the traditional ACEs, and this is what's used in the scoring algorithm. The Pearls also has a part two, and the part two are really social determinants of health. Or additional adversities that can increase risk for toxic stress physiology, but do not yet have population level data to indicate that they are associated with those outcomes. So these are categories where we know they have an impact, can be a risk factor for toxic stress, but really this is an additional section that provides us with more information about exposure, but truly part one is what we're going to be using with respect to scoring. All right, so the tool has two parts, the traditional ACEs and then the additional adversities. The Pearls then comes in 3 different versions. So we have the Pearls Child tool. So this is for children ages 0 to 11 years of age, and this is completed by the caregiver. So the form that I have up on the screen today is basically that particular tool. We also have the Pearls Adolescent tool. So this is for ages 12 to 19, and that is also completed by the caregiver. The third version is the Pearls for Adolescent Self-Report tool, and that is for children 12 to 19, or adolescents and young adults, 12 to 19, and this is a self-report version, so it's actually completed by the adolescent. So what would happen is if I were to take my 9-year-old to the well child visit at a clinic that was screening for ACEs, I would be given this particular tool, the Pearls for 0 to 11, that's completed by the caregiver. If they were giving me the de-identified version, which is what you see here, I would be going through the list and telling how many of these categories of exposure my child has been exposed to. And then I would be putting the number in the box at the bottom right of the first sheet there. Then I would be going to part two and once again reviewing the different adversities and identifying how many my child had been exposed to. So I would ultimately be putting 2 numbers in, a number for the traditional ACEs and then a number for part 2, or those social determinants of health. If I were given an identified version of this tool, which actually asked me to indicate which ones my child has been exposed to, once again, I would be checking off which adversities my child has been exposed to and then putting in a total number for section 1 and then for section 2. So there are the 3 versions, so the 0 to 11 that the caregiver completes, the 12 to 19 that the caregiver completes, and then the self-report for the adolescents. For patients coming in who are 12 and older, the recommendation is that we administer both the self-report and the caregiver report. So you're actually obtaining 2 reports on that particular child's exposure. I will just mention that what we have found is that adolescents actually do report greater exposure than their caregivers. So you may get 2 different accounts with the adolescent most likely reporting more exposure. And so the clinical guidance is to actually look at the report that indicates the higher score and to actually record that and use that score for reimbursement for the Medi-Cal screening. Okay, I'm sorry, let me see if I can go back. There we go. So another component of the screening process is not only the score itself that you obtain through the Pearls tool, but also to consider clinical symptoms or signs and symptoms of toxic stress physiology or this dysregulated neuroendocrine immune functioning. So in addition to the actual score, we're going to be looking for inflammatory responses. So things like frequent asthma exacerbations or frequent colds, endocrine system responses, so obesity or poor growth, but also neurological system responses. And so these things might be behavioral problems, difficulty sleeping, self-harm, problems in school. So once again, the ACEs screening tool, the Pearls, will give us a concrete number around exposure or dose of adversity, but really we're also collecting information throughout the visit and then using this additional information to really guide what our next steps will be. All right, so this is available on ACEs Aware, but I'll kind of quickly go through this process. So the workflow, really determining once you have a tool and a desire to begin screening for ACEs, what that workflow will look like. And so in most practices who are implementing ACEs screening, it is the medical assistant who is introducing this particular screening tool. And there are specific scripts that are available via ACEs Aware, or we can definitely talk about how to present this, maybe in the Q&A section. But basically what's happening is that the tool is being introduced, it's being normalized. We have some wonderful templates for posters that can be hung up in clinics that say, we screen everyone because we understand that stress and trauma can impact health. So this idea of normalizing the process, giving our staff tools on how to introduce this and talk about it, obviously always recognizing that if a client or family has questions about the screening tool, that they can actually speak to their primary care provider about it. They can also choose not to complete the tool. We also definitely see early on that some individuals may report very low scores or report scores of 0 and 0. But later, as the relationship really develops, they begin to feel more comfortable sharing what the true exposure is and really engaging in further conversations with their providers. But most often the workflow does start with the medical assistants. And so the caregiver and or patient are completing the ACEs screening tool. And then that's being reviewed by the primary care provider and then integrated into the visit and really reviewed with the family based on the score itself. All right, so with respect to the algorithm, I mentioned that for this ACE screening process, what we're looking at is part 1, or exposure to the 10 traditional ACEs. And so we're using that score, or the score on the top box, or the box at the bottom of page 1 of the Pearls tool, to really think about risk for toxic stress physiology, and then thinking about what the intervention will be that follows. So for an individual who comes in and reports a score of 0 in part 1, what we're really wanting to do is to provide anticipatory guidance and education around why we're screening, why talking about exposure to adversity and stress within primary care makes sense, why we want to continue to have these conversations, especially if you are going to be moving forward with annual screening, really setting the stage for that being part of the regular conversation. How is your family doing? Have there been stressful life events? How are you managing stress? How do we see that show up? So a score of 0 really introduces the conversation and allows us to set the stage to talk about ACEs on an ongoing basis and to really reinforce things that are already positively happening within the family. So that would be low risk for toxic stress physiology. So if someone actually scores a score of 1 to 3, once again in part 1, what we're going to be looking at is those additional signs and symptoms. So that list that I had quickly reviewed around neuroendocrine immune responses. So we're going to be looking to see if there are these associated health conditions that would indicate that because there has been some exposure, they're also having these additional responses, which put them then at an intermediate risk for toxic stress. So for folks without associated health conditions, once again, we just want to provide the context for why we're screening and provide psychoeducation and support and set the stage for continuing to have these conversations. If someone scores in box 1 a score of 1 to 3, and they do have associated health conditions, or they score 4 or more, then at that point, we really do want to consider a more direct intervention. So I'll be talking a little bit about that, including what that looks like with respect to a referral for additional behavioral health services. All right, so interventions. So as I mentioned, if an individual is coming in reporting no or very low exposure to adverse childhood experiences, then we really just want to once again reinforce why we're doing universal screening and normalize the process and provide education. Some of the educational tools that are available out there include double-sided handouts on what are adverse childhood experiences, what is toxic stress, and some of the sites that I go to for these resources include Stress Health, that's stresshealth.org, the National Pediatric Practice Community on ACEs, or the NPPC on ACEs, and there you can actually join and get access to psychoeducation materials, tools, workflows, and really lots of support in how to actually implement ACEs screening in your practice. ACEs Aware also has these resources available. If you go under resources and you click on the drop-down menu, it's actually pretty easily categorized into general information and then information on the 6 pillars of wellness that are promoted via the ACEs Aware initiative. All right. So clinical interventions here, once again, if someone does fall into that intermediate risk area, or perhaps are actually in the higher risk area, but are really kind of not ready for perhaps more advanced kind of interventions, then really the proposal is to focus on these 6 domains of wellness and really building upon the family protective factors and the capacity for caregivers to provide ongoing buffering. Of course, if there are associated medical health conditions, we of course want to increase surveillance and move towards disease management. So one tool or framework and tool that is promoted via ACEs Aware is really looking at the 6 domains of wellness. And these very much align with the resiliency skill building that Dr. Swick had mentioned earlier in her presentation, and really kind of looking at these domains of healthy, supportive relationships within the child's life, sleep, which once again is so significant and yes, should be prioritized if you're going to start somewhere, nutrition, regular physical activity, mindfulness practices, and then of course access to mental health services when appropriate. So if we really are thinking about how do we promote these core areas of wellness within our primary care practice, there is one particular tool that has been introduced via ACEs Aware. This tool is available for both children and then also for adults. It's called, for children, the ACEs Aware SelfCare Tool for Pediatrics. So this is really a tool that can be introduced by the primary care provider for, once again, individuals in that intermediate or high risk level. And it really is a collaborative tool to work with a child and caregiver to identify what area of these 6 domains of wellness they would like to focus time and attention on. So it might be healthy relationships. So what can we do to cultivate healthy relationships? And this tool provides ideas. How do we increase regular physical activity? Or how do we introduce mindfulness practices? So I will say, in talking to primary care providers who've begun ACEs screening, that this has been identified as a really valuable tool to once again be able to manage and really provide intervention for children who do have exposure, but who do not require a referral to behavioral health services, or who may not be ready for that referral or handoff for a behavioral health intervention. So once again, I'd recommend this particular tool that is available on the ACEs Aware website. All right, so lastly, I know I'm out of time, I will just mention that for those individuals who really are at that higher level of risk, so there is a dose of exposure to adversity plus signs and symptoms of potential toxic stress physiology given the associated medical conditions, it may be needed or required or indicated that child and family be referred for additional therapeutic interventions. And so many of you identified that you do work within clinics with integrated behavioral health. And so there are many opportunities to be able to work out workflows in which the screening and then the introduction to your behaviorist can happen, ideally via a warm handoff, potentially even during that visit, where the behaviorist can come in, really provide additional support and containment, and then work with the family to identify how they can continue to provide support. Once again, always within that ACEs and toxic stress framework, thinking about how to build individual skills for the child, as well as how to increase the caregiver's capacity for buffering, which really are the primary focuses when we are doing an ACEs-informed intervention. So I will stop there, and thank you all for listening, and of course then be ready to transition to questions and answers.
Unmute. Hi, just starting myself up again. Thank you so much. Can you back up to one slide, please? I just wanted to remind everyone or show you all the registration link, which you can find by going to acesaware.org. That'll be a fantastic webinar tomorrow featuring Dr. Burke-Harris, but also Lisa with us. Thanks so much. So next slide, we're going to go to our question and answer period. And let's see, I'm going to, it's on my phone. Okay, let's see. I have a, I'm going to, actually, while I'm searching for the question, Doc, Susan, do you want to put on your video and add your sound? That's what I would like, is have it up there. Great, thanks.
Okay. Is it working? Mine's on, but I don't.
You're on now, thanks so much.
Okay.
Great, okay. Let's see, there's a question that I think both of you can answer. Can you speak to time frame? How long on earlier steps or signs? Let's see. I guess there's a question about how much time to spend with folks when you're eliciting such difficult material, and how to navigate addressing what has been brought up in the room versus going to a referral. Kind of, how would you navigate that territory? And I hope if the person who asked the question wants to clarify more, if I missed the essence of your question, please send in to us. Thanks so much.
I guess I can jump in. So really in thinking about using a specific ACEs tool, once again, thinking about that algorithm. So you're going to have one piece of data, which is actual score. So you're going to be looking at the score for 1, the score for part 2, And then as you're kind of proceeding with your medical appointment and the medical history for that youth, sorry, there's an echo. Not sure if everyone else maybe is on mute, if that would help.
Susan, you want to mute while
Sure.
Perfect. So once again, kind of taking the ACEs screening tool score, but then also put that in context of other presenting signs and symptoms. So I would say if it is a low score, really providing that anticipatory guidance, that framing of we screen everyone, why this is important, usually just takes a couple of minutes. Obviously, if it is a higher score, and especially if you're using either like an identified version, and so you actually are seeing which adversities the child has been exposed to, that will definitely require more time. So once again, that's the decision point you need to make around using a de-identified versus an identified version. Most frequently, I've worked with clinics who use the de-identified, so we're really talking about dose of exposure and connecting the other medical conditions within a stress framework. So often that can be woven in quite naturally into the other work that's happening within the medical appointment. Very often, because of time, providers may choose to kind of build on the conversation. So they might, really phase it in. So we're introducing why we do this, what the score might reflect, putting in the context of stress, putting in the context of other medical concerns, and then bringing the family back. So if you do have someone with higher ACEs exposure and exacerbated asthma, there's going to be increased surveillance and follow-up, and that also then gives you an opportunity to continue to return back to the conversation about ACEs and toxic stress and what the appropriate intervention might be. So it might be starting really slow, just thinking about, stress can exacerbate asthma. So what does that look like? Like, how are we managing stress for this child? How is the sleep? How are they moving on a daily basis? And so it's really woven in this idea that it doesn't have to all be addressed in one session, that this is really something that you build upon, and that you might not actually ever be making a referral or a warm handoff to a behavioral health provider. We may be able to manage this all within the relationship with a primary care provider. But it may be something that as you continue to build, the family becomes more and more open to accessing additional support and services. And so then that warm handoff or that referral can actually happen later.
That was a lovely and thorough answer. And I would just add that I think it can be helpful. Look, we all wish that we worked within a healthcare system that was truly integrated and comprehensive. And I'm not going to pretend that it's easy to access behavioral health services. But I do think it's important to recognize the leverage and power that each of us has as healthcare providers with our patients, and that merely making these topics talk aboutable has an immediate therapeutic effect in a safe setting. But if in doubt, I would also suggest, particularly right now where telehealth visits are possible, that trying to have more and brief connections with the family that you're concerned about is actually a good strategy. So until you can, if you think there may be need for a referral, you invest some energy in finding that. But I would preserve your energy for cases where you're really impressed with the degree. So from a behavioral health standpoint, you're really impressed with the degree of symptomatology, right? You're really concerned about suicidality, addiction, a host of problems presenting in a child or teenager, where you think we really need an expert team to manage this disease. When you know about risk and you're not sure about symptoms, I would instead try to have more frequent brief contacts where you get to do a lot of education about health promotion. And maybe you want to pick one area in each contact where maybe you start with sleep. and you as the physician or the nurse practitioner or whatever role you're is, prescribe 8 hours of sleep a night, and you prescribe a practice run of changing sleep habits, whether it's all screens power down, ideally 60 minutes before lights out, no screens in bedrooms. Start with 3, because people can't change a lot of habits at once. But start with 3 and prescribe something, and then have them come back to you in 2 weeks and see how it's going. So just get a little more invested and involved in helping your patients to work on small behavior changes that may mitigate their risk. So even if you think that there may be significant symptoms that are going to require treatment from a behavioral health expert or maybe from an endocrine expert, you still can very powerfully invest with your patient in health promotion strategies, in behavior modification strategies with your adult patients, with your child and adolescent patients, and with their parents in particular, that can have a very potent effect, whether or not they're dealing with a major psychiatric illness that's a sequela of their risk. It's still very powerful for them to work on the resilience strategies we were talking about.
Thank you. Thank you so much. I'm going to go to a very short question. I think the previous one addressed actually a number of ones that had come up. Are ACEs screenings only covered by Medi-Cal? And the question was for children, but actually Medi-Cal covers children and adults. And I actually don't know whether private insurance is covering the ACE screening. Do either of you know?
I'm not aware that they are. Yes, for Medi-Cal, so it really is 0 to 65.
Right.
And so for children, of course, as I mentioned, the screening can happen as appropriate, medically indicated, but no more than once a year per provider managed care. And then for the adults, it really is one time after the age of, so it's between 21 and 65, basically, having one provider or managed care plan.
And just a reminder, we have to mute when the other person's talking, I think, or at least Susan, I think you do. But I think it's once a year for adults, no?
I can look that up really quickly, so yeah.
Gail Newell adds, for adults may repeat with a change of primary care provider. Oops. And Susan, you're muted. You're still muted.
How about now? Okay. I need to build technological resilience. I'm not sure about commercial insurance, although typically commercial insurance isn't great at reimbursing for very specific procedures within a behavioral health visit or a screening visit. But they will reimburse for time. So if you integrate the screening into a timed encounter, that's part of an initial evaluation, or part of a primary care visit, where a portion of the time spent is dedicated to counseling, then you can integrate the time required for screening into the visit and bill for the time.
And I did just find the language actually for adults age 21 through 64. So it's permitted once in the adult lifetime through age 64 per provider or per managed care plan. And then screenings completed while the person is under age 21 do not count towards the one screening allowed in their adult lifetime.
Thank you. We have a question about a bit more about telephonic and video telehealth for ACE screening, especially with regards to confidentiality and how you might suggest. I'm hoping that telehealth is here to stay because it really has expanded access for many of our folks. Can you talk about that, especially for adults?
All right, I'll take this one first. I do think confidentiality is a concern with telehealth, particularly where we can't be 100% certain about who else is in a room. I know with psychotherapy visits with adolescents, trying to ensure that they're not sitting outside in a public place with their cell phone as their camera is always a challenge. And in some ways, the best we can do is inform them about risk and have it be part of our initial release when we're doing telehealth. I also think telehealth visits are exceptionally well suited to visits that are very much focused on sort of educational interventions. From a psychotherapy perspective, our work with some of our sicker patients is sometimes the most delicate or difficult work to perform with a video interface, because you can lose some of the nuances of tone, of voice, of eye contact that can be helpful in psychotherapy. But in educational interventions, often the video interface is absolutely perfect. It's just right. It's really gets the job done, like I think it is hopefully this morning for all of us. I found it works really well in discussions and encounters with parents. We have little evidence to guide us in this regard. Hopefully we'll have more in the next 5 years because of this period, and hopefully we get to keep this resource. But what evidence we do have sort of supports my clinical impression. It's always nice when the evidence supports your clinical impression, but where educational interventions and direct work with parents is very well served and much more likely to be sustained or complied with, because it's a lot easier to make it to a video visit than it is to leave work early and show up for an in-person visit. So I think that acknowledging the risks to confidentiality, informing, making it part of a consent process, and then taking full advantage of this, our capacity to lower a barrier to access care, and particularly education. You can write a prescription for sleep and talk about sleep hygiene very effectively over a video visit.
I have nothing to add to that. I think that was, yeah, perfectly stated.
Great, thank you. How much training do you recommend for medical assistants, and how was their own trauma addressed if triggered by these questions? I think really important question.
Yeah, I can definitely talk about my experience in supporting the training of the staff at the Baby Child Health Center. So it was a small clinic. There were about 5 medical assistants. I think when we started really formally screening for ACEs, I will say that Nadine Burke-Harris, as the pediatrician in that clinic, kind of started informally screening for ACEs early on. And then it was really a process of developing a tool and a strategy and workflow. And then at that point, really thinking about how we trained the entire staff to really be prepared for this work. So I will say that first steps really included just education on ACEs, and really introducing it as something that is common, and really recognizing how common it is, well, across all populations, but then also for individuals who gravitate towards health and behavioral health fields of work. And so that was really the first step, this recognition and just building awareness and understanding. And I think bringing in that toxic stress lens also just gave a sense of understanding this idea that this can happen to all of us and that these are common responses. So really to normalize it was really those initial steps. So lots of education in small doses, because trying to find time within a pediatric clinic to do even a 2-hour training like this one today is really challenging. So really thinking about what we could introduce within smaller sections. So 15-minute kind of check-ins with folks, how to introduce just even some of this context within daily huddles. How do we introduce and build out more capacity for supervision so these conversations can be held within group settings, but then also individual settings where someone is meeting with an individual supervisor and being able to really reflect on it in a deeper way. So really it was education and kind of building that capacity. And then we really then developed a formal training protocol, which included in-person trainings, PowerPoint presentations, handouts, time for role playing, and scripts. So the medical assistants really wanted to understand, like, well, how do I say this when I introduce it to a client or a family? What if they ask this question? So really learning about the types of questions that they were anticipating and giving them specific tools and the ability to practice with one another on how to navigate those conversations. And then also really building their understanding that if there is a question that they couldn't answer, that they could say, this is something that your primary care provider can follow up with you on, or giving them specific language on how to then move it to the next level. So that also meant lots of training with our primary care providers. And Nadine, obviously being this champion, was really helpful in that whole process. But really understanding, what the medical assistants would be holding, what would then be held by the primary care providers, and really scaffolding the training that we were doing and the support. Because we were lucky enough to have the behavioral health and really embedded behavioral health providers in the clinic, we also really built out the capacity to do debriefing and consultation. So our behavioral health providers were available. Providers can just check in and say, I've just had this interaction, this is how it went, I'm not quite sure what to do next. So these were all strategies, but once again, it was really building out that infrastructure and starting with training, and starting with the recognition that people were going to have different reactions and that they'd have questions, and that we were going to spend time really addressing those together.
Thank you. If it's okay, Susan, I'm going to move on to, because we have lots of questions building up. So two that are combined, how can ACEs be quantified in populations with language barriers or religious beliefs? And then a question that's really very similar, could you speak to cultural considerations when administering the screening, and then further engagement with clients and families? Lisa, that might be you, since I think it's one of your areas of expertise.
All right, well, I can definitely jump in. So, the first, I think, is really recognizing that this is a self-report for the youth if they're 12 and older, or a caregiver report, and kind of this expectation, or kind of loosening the expectation that it's going to be accurate, or the most truthful. So I think in some ways really kind of recognizing that this is one particular tool that gives us a snapshot and a piece of the overall information, but that ultimately that's not the only information that we're going to be using to really think about exposure to adversity and stress. So I think in some ways when folks start screening, well, one of the things we actually did see quite a bit is that, medical assistants would be introducing the tool, they would receive it back, and then they'd be giving it to the primary care provider. But in small communities, folks may know about people's histories or backgrounds to certain extents. And so there was this huge concern about, like, I know this isn't accurate. I know that their, exposure is higher because, they came in for a visit, 2 years ago and this was disclosed. So very much early on, there was this sense of, like, it isn't accurate, so how helpful can it be? And especially concerns around certain populations. At the Baby Child Health Center, it was about 70% or slightly higher Black families, and then about 20% Latinx. We had a small population of Pacific Islander families, and there was a real concern about the acceptability of the screening process and the tool for that particular subset of our patient population. So I think a piece of it is kind of loosening some of those expectations that this is going to be accurate reflection. It really is starting the process and part of a conversation, and ultimately you're going to get the most useful information through the relationship. And so this is just one piece But the other pieces are going to be looking for those signs and symptoms of associated medical conditions, the conversations that you're going to be having as you build the relationship with the child and with their caregiver and family. So I think just as a brief answer, I think that's really kind of where we start. Of course, these tools, have been translated into various languages. The Pearls is in the process of being validated. So there is a published article looking at the development of the Pearls tool and the initial face validity, and that's a really diverse patient population that came from Children's Hospital in Oakland. That is, a location where they do a lot of research, primarily work with families of color. We're doing interviews with folks. So they did de-identified screening and then sat down with families and did the identified version to really understand how they were responding to the items, why they maybe didn't indicate certain exposure. So there is a robust process of really looking at this particular tool with a diverse population. And we anticipate some more publications coming out, really looking at further validation and really looking at ACEs exposure and relationship to behavioral health outcomes, as well as biomarkers. So that is something that's also going to be coming out of this BARC initiative.
Thank you so much. And I think we're going to have to close our questions. I know that there are many others, and I might ask, actually, Susan, you need to mute yourself. There we go. Thank you. So we're going to move on, but I believe that we'll be sending answers to the unanswered questions. I'll navigate with Susan and Lisa about that. And we're going to do a word cloud now. How are you feeling after having heard these conversations? So take your cell phones out, or the link will be in the chat box. We're really curious. So text to 22333. So text, go 22333, and then put in HIP admin 505 as your first text. So I don't know if you can keep the directions up. HIP admin 505. Can you keep that? It is? I'm not seeing it. Okay. It's in the chat box. Okay, so look at your chat box and then tell us how you're feeling. And this has the capacity for something like 700 words. So you actually can put in more than one, just truth be told. So this is wonderful for us as preparers of this presentation to hear from you. As Susan and Lisa shared, not seeing your faces is challenging. And so getting these words from you is wonderful. We really appreciate this. And I just want to give a shout out to Shelley Barker, who has held this ACEs screening as a wish and a hope with me. I think it's been 3 years or so that we've been wanting to present this, and I can't think of two better presenters than Susan and Lisa to have joined us. Also, Dale Bishop from Central California Alliance for Health has been incredibly supportive. And just another shout out that we hope that all of you will be even more prepared by joining the ACEs Aware 2-hour CME, and that accreditation allows you to bill and get paid for doing the ACEs screening. I want to also add that in preparing for this session with Lisa and Susan, we felt very clear that we wanted to have a follow-up. And so let us know if that is something of interest to you, to have a follow-up with Susan and Lisa, perhaps in 6 months when you've been doing a few months of this with your patients and in your clinics, so that we can, and we'll probably spend less time on the presentation and more on hearing your questions so that we can dialogue together about what it's like in a 20-minute visit, as one of the questions asked. Like, how do you do this when you've got all the other things to do in 20 minutes? Look at this, how it's forming. Thank you so much. Excited, hopeful, informed, inspired. We will definitely take a screenshot of this to share with all of you. We will be sharing with you the slides from both Lisa and Susan. They will come to you in an email along with this word cloud, I hope. And then in your chat box, you will have the link to the survey. Please fill out that survey, include the beginning code and the ending code, which I will tell you is 8825, the end, and then the code that 9963 from the beginning. Then you've got your CME, but you have to tell us how it was. We really look forward to your suggestions for improvement. Lisa and Susan, please take yourself off mute, even if that will ricochet a bit. Thank you so much for joining us. It was so inspiring to me personally, and I'm sure to everyone. And George Floyd, well, forgive me.
Thanks, everyone.
Thank you.
Thank you. Have a wonderful day. Thank you so much. Keep up the fight. And the love.
And the hard work.
And hard work. Yeah. And then we'll be
Resilience.
resilient.
Yeah.
Okay. Thank you, everyone.